Reanne's an oncology nurse practitioner. She's working on her PhD still.
I haven't started yet.
Soon.
Reanne has spoken to our group about 3.5 years ago, and we're really pleased that she's coming back. And her clinical interests, as you can see there, are symptom management, sexuality, cancer, quality of life, palliative care, as well as advanced care planning. She's working on her doctoral research, which involves examining the experience of sexuality in individuals and their partners following hematopoietic stem cell transplantation. That's still the case, is it?
That was my master's research, and that study is done, so we'll do this.
Excellent.
So just like to thank Kelly and Dave and all of you for the invite to come back to speak about sexuality and prostate cancer. Again, as has been mentioned, I was here a couple of years ago and spoke on this topic back then. So just to start, I don't have any relevant conflict of interest to disclose. Just a quick disclaimer, this information tonight is just information. It's not intended to replace any medical advice, and definitely don't make any changes to your current treatment plans without consulting your physician or healthcare provider. The other disclaimer I'll add in here too is when that camera rolls, I get very nervous and jittery and stuttery and make up words like stuttery, and I apologize in advance for that. Hopefully we'll get going here and I will ignore the camera. So tonight I would like to discuss the following. What is sexuality? What are some common changes in sexuality that may occur after prostate cancer? How can altered sexuality and altered sexual function be managed? And then I'd like to, if possible, if you're open to it, have a Q&A period. And I did receive a couple of questions by email, and I'll address those as we go along. So I did have an interactive poll that I wanted to ask you some questions, and it's kind of nice because it's anonymous. It allows you to vote on your phone, so I can't tell who's answering and who's saying what. But the next time I come back, Kelly, we'll have the technology sorted out, and hopefully we'll be able to do that at that point. As was mentioned, this is the link to the video in the past. At that point, I think I only had 5 thumbs down. Now I have 7 thumbs down out of about 18,000 plus views, I think. So I suppose that's not too bad. So just to start, when we talk about sexuality, we're not talking only about sexual function, but also to make the point that sexuality really, it's a central aspect of being human throughout life. This is the World Health Organization's definition of sexuality. It's not succinct, it's quite comprehensive. And just to make the point that sexual function may be part of sexuality, but it's not the only part and certainly not the defining part. I think perhaps a more enigmatic question might be, what is sexual satisfaction? And what's required for sexual satisfaction? Do you need a partner to be sexually satisfied? Do you need an erection to be sexually satisfied? Ejaculation? Can you be satisfied without an orgasm? Do you need emotional intimacy? There was a study done a couple years ago, published in the Journal of Sex Research, that asked this question to about 700 or so participants, male and female. All participants were heterosexual and they were involved in a committed, exclusive relationship. But they found some themes in this study, and the first was focusing on the positive aspects of individual sexual experiences, such as pleasure, positive feelings, arousal, sexual openness, and orgasm. The second theme was really looking at relational dimensions, such as mutuality, romance, expression of feelings, creativity, acting out desires, and frequency of sexual activity. But their big findings in the study were that sexual satisfaction really derives from positive sexual experiences and not from the absence of conflict or dysfunction, and also that the most commonly described terms were feel, pleasure, activity, relationship, partner. Coming in last was orgasms. So interesting to know. Cancer and sexuality is very complicated. People come into a cancer diagnosis with many things that might influence sexuality, things like culture, religion, partner, previous experiences. And then the cancer diagnosis and subsequent treatment also can impact sexuality. Sexual function really relies on intact nervous, vascular, and endocrine system function. And a huge part of that also, I think, there's a psychosocial component as well it's equally important. And lots of different things, again, that can precede the cancer diagnosis or happen after the cancer diagnosis that can impact the experience of sexuality. I think when we look at sexuality across the illness trajectory, there's some important considerations. So my study on bone marrow transplant patients, one of the participants said to me, this is a really important topic, but I don't know how I'd feel if my doctor would have said, you have cancer, how's your sex life, in the same sentence. So at diagnosis, it might not be the most important thing to bring up, but there are some considerations around the time of diagnosis, such as fertility preservation. If that's important to the patient or couple, it's something that should be discussed at time of diagnosis because we need to look at fertility preservation strategies before treatment starts. At the same time, that is really a crisis phase, and it might not be the best time to talk about sexuality for all couples. During treatment, while people are going through surgery, chemoradiation, hormone therapy, for example, there's some practical considerations. I've had patients ask me, can I actually participate in sexual activity? Should I be using condoms? How long do I have to use condoms? Are there any risks to my partner? So those are some practical considerations around treatment. Managing symptoms, dealing with bleeding and low platelets and low neutrophils and risks of infection. And we talk about certain sexual types of sexual activity that might not particularly be safe during times of really low neutrophils and low platelets. Recovery and survivorship, I think, we talk about this a lot and trying to get back to normal or the new normal, and trying to figure out how to navigate kind of the landscape after treatment is finished. And that can be very challenging as well for patients and partners alike. And then also during advanced disease and at end of life, I think sometimes this area gets overlooked, particularly when we talk about sexuality and sexual function. But this is a time when many people are really looking to preserve intimacy, physical and otherwise. Emotional intimacy as well is very important. And we sometimes forget that this is really important during advanced disease and at end of life. So prostate cancer and sexuality, I know everyone in this room is probably very familiar with the different types of treatments that we offer for prostate cancer. And there really are many modalities of treatment for prostate cancer, and there's some overlaps, I think, in terms of the types of side effects that are caused by each type of treatment, and there are some differences as well. And I think each person, each individual comes into the diagnosis and treatment, and they may react differently. So you might have identical treatment as the person sitting next to you, but you might have a very different response and different side effect experience. Today I'm going to focus mostly on the sexual side effects of prostate cancer and treatment, but there are a bunch of other side effects that we don't necessarily call sexual side effects that can also impact sexual function. So bladder and bowel incontinence, fatigue, nausea, vomiting, all of those kinds of things can impact sexual function and sexuality. I think also watchful waiting. Sometimes people think, well, watchful waiting doesn't really have any side effects associated. I think watchful waiting, though, comes with a very significant source of anxiety and potentially a sense of fear for many people as well. And that can also negatively impact sexual function. This is very difficult to read, I know, but I was very pleased to see in the Journal of Sexual Medicine this year. This was just published a few months ago, and it was a two-part series looking at sexual rehabilitation after treatment for prostate cancer. These are recommendations from the 4th International Consultation for Sexual Medicine. And it's not just after treatment. Some of these points in here speak of the need to discuss the sexual side effects of prostate cancer treatment up front. And so really encouraging clinicians to have very frank conversations with patients and their partners up front before treatment even starts. Some other notable findings from this two-part publication. Right now they're saying there's insufficient evidence that a specific surgical technique, so open versus laparoscopic versus robot-assisted radical prostatectomy, promotes better results in erectile functioning. We know predictors of erectile function recovery are younger age, pre-op erectile function, and bilateral nerve-sparing surgery. We know right now that there is conflicting data as to whether penile rehab with PDE5 inhibitors, so the medications, improves recovery of spontaneous erections. Again, data are inadequate to support any specific regimen as optimal for penile rehab. And just making the point that men undergoing surgery, radical prostatectomy, any technique, are at risk for sexual changes other than erectile dysfunction. So decreased libido, changes in orgasm, lack of ejaculation, Peyronie's-like disease, and changes in penile size. So all of these things are now really being emphasized to clinicians that they need to be discussed with patients up front. So again, just to briefly speak about some of the treatments that we offer for prostate cancer. Radical prostatectomy, again, as I mentioned, you can have the open procedure or the robot-assisted or laparoscopic assisted. The difference is the open procedure's got quite a big incision. The laparoscopic or robot-assisted, you get a couple of little incision sites throughout the abdomen. Really, both can cause some significant changes in sexual function afterwards. We look at difficulties with erectile function, loss of ejaculation or diminished ejaculate, penile shortening can happen as well. For androgen deprivation therapy, if we're using orchiectomy as a means of androgen deprivation therapy where we're surgically removing the testicles, that can also lead to diminished libido. There can also be erectile dysfunction. And transurethral resection of the prostate is usually used in non-cancerous or benign diseases of the prostate. But it's sometimes used in men with advanced prostate cancer, metastatic disease, not as a curative option, but more to manage symptoms. But that involves sticking it's a resectoscope through the tip of the penis, through the urethra to get out chunks of the prostate that way. And so that can also lead to some changes with erectile function and notably ejaculation as well, where there can be retrograde ejaculation where the semen goes into the bladder as opposed to coming out through the urethra. So a lot of changes that can happen. Some of these changes can happen quite early post-operatively, and it can take up to 2 years or more to regain erectile function after surgery. What else to say about that? I think that's the most I wanted to mention about that for now. Radiation therapy for prostate cancer typically will consist of external beam, and that's the picture at the top here. I don't know if my mouse will work. Can you guys see that? No, you can't. So it's the picture at the top of the screen. That's external beam radiation, or brachytherapy, which is internal radiation. Sometimes there can be a combination of both that's used. And after radiation, the potential impact on sexual function can be erectile changes. And those can actually get worse for the first couple years after radiation rather than getting better. There can be decreased volume or absence of semen. There can be discomfort during ejaculation. There can be blood in the semen. There can also be changes with decreased libido, decreased intensity of orgasm, and overall decreased satisfaction with sex. The etiology or the reason for the damage they think is likely vascular, so it's likely caused by radiation damaging the arteries in the penis, but also can be caused by damage to the nerves as well. They're getting better with techniques and techniques such as intensity modulated radiation therapy that allows us to give an adequate dose delivery with improved sparing of the normal tissues around. And also hypofractionating can also improve outcomes to some degree. Most of the studies so far have been comparative. They're not trying to prove superiority of these different techniques, but rather non-inferiority. So saying that they're not necessarily worse in terms of survival, but they want to make sure that, that they're not causing worse survival. So in terms of the sexual side effects, the jury's still out with many of those. Proton therapy versus photon therapy. So photon therapy is what we use right now. In some centers in the US, I believe we don't have any proton therapy centers yet in Canada, but in the US and other parts of the world, they've got proton therapy, which allows kind of a more specific dose of radiation to be delivered. So the analogy I read on, it's called Health After 50, it's a website, talks about the difference between X-rays or photons and protons. It says, imagine that an X-ray is a bullet that enters the body, strikes a tumor, and then exits through the other side. And throughout that process, the X-ray releases energy and damages healthy and malignant tissues alike. So it's getting the cancer, but it's also getting normal tissue that's adjacent to the cancer. And by contrast, with proton therapy, you can kind of pinpoint exactly how deep in the body you want the proton beam to fire, and it goes kind of directly to that site and spares some of the healthy tissue. In theory, it sounds great, and so far the clinical studies have not really proven it to be significantly different in terms of sexual side effects and other side effects. It's also quite expensive. And so it's an option for people who have cancer that's not spread outside the prostate gland itself. And also if you're willing to be able to travel outside of Canada and pay for it at this time. It's not something that's offered in Canada as part of standard therapy. Hormone therapy, so we know that in the presence of testosterone and androgens, prostate cancer cells can grow. And so if we deprive those cancer cells of androgens, then we can effectively slow or stop their growth. And so we can, take away or mitigate this by decreasing androgen production by the testes, so we can either surgically remove the testicles or give medications that will effectively do the same thing. We can block the action of androgens in the body with medications, and we can block the production of androgens in the body with medications. And some potential side effects of androgen deprivation therapy include decreased libido or desire, erectile dysfunction. There can be hot flashes, weight gain, fatigue, gynecomastia or enlarged breasts, decreased penile length, and decreased testicular size. So overall, changes in sexual function, I'll address them a little bit more specifically, just starting with libido and desire. I think way back when Masters and Johnson came up with the sexual response cycle, we thought definitely you need desire first. And it was almost a linear process where you needed desire, that was followed by arousal, that was followed by orgasm, and then a plateau period and resolution. We know that there's no such thing now as a normal sexual response cycle, that you can have arousal without desire, you can have orgasm without desire or arousal, really. Even you can have multiple orgasms. It's just very unique and very individual. A lot of work has kind of been done more in the female sexual health world in terms of libido and desire, especially in recent years with the push to try to get medication for hypoactive sexual desire disorder to market. Just speaking about what is it about libido and desire, how does that all work? And we know that in the studies they've done with women, that you don't need that spontaneous desire, and you can jump into the sexual response cycle really at any point, and you can go on to have a very satisfying and meaningful sexual experience in the absence of spontaneous desire. And so I think if we get our heads around that, I think that is very optimistic, that you don't need to necessarily have spontaneous desire. And I think desire is complicated. It's influenced by a lot of things. It's influenced by one of the biggest sexual organs in the body, which is the mind, the brain. And I think also it's influenced by the other parts of the cycle as well. So if you're having painful erections, or you're having no erections, or you're having painful ejaculation, that will negatively influence desire. Your mind is going to interfere there a bit and say, if this is going to be a painful or upsetting or disappointing sexual experience, I don't really want to be part of it. And so we can see how different aspects or different parts of the sexual response cycle can negatively affect the other parts. I just think, as we age, some of these things will change anyway. They're part of normal aging. And really, we see in our sexual health clinic at the Cancer Center now, decreased libido and desire is one of the number one complaints amongst any of the patients we're seeing. So the women, the men, doesn't matter what kind of cancer they've had, it doesn't matter what kind of treatment they've had. That experience of being diagnosed with cancer or diagnosed with any medical condition is very difficult, and that can already be a libido killer. And then the medications that we give for many different types of conditions can also affect libido. And again, if they're affecting other parts of that sexual response cycle, that can in turn affect libido as well. But there's lots of good news, and I'll get to that in a few minutes about how we can work around that. So changes in erectile function, we know definitely there can be changes in erections after prostate cancer treatment. So there can be difficulty achieving erections, difficulty maintaining or sustaining erections. There can be insufficient firmness or rigidity for penetrative intercourse, either vaginal or anal intercourse. And we know that for anal intercourse, erections need to be approximately 30% more firm to be able to have penetrative anal intercourse. We also know, again, that more than 50% of men over the age of 40 have some degree of erectile dysfunction. This is something that can happen with many different medical conditions. Medications can influence this, and just even normal aging can influence this. The good news with this one is erections are not necessary or required for orgasm. but we definitely do know that we can change erectile function after prostate cancer treatment. So what are the mechanisms? Again, we know that there can be damage to the nerves that influences erectile function, damage to the blood vessels that influences erectile function, hormone changes, and this is testosterone here, that can impact erectile function. There can be some anatomic or musculogenic, so in the cavernosa in the penis, or the muscles in the penis that can be affected, and that can influence erectile function. And specifically, we see there can be loss of compliance of the penile sinusoids associated with increased deposition of collagen and decreased elastic fibers. That can happen with diabetes, that can happen with high cholesterol or other types of vascular disease, penile injury, or old age. We also now know that erectile dysfunction can be an early warning sign of cardiovascular disease. So if there is arteriosclerosis or atherosclerosis happening in the penile arteries, that can also be happening in the coronary arteries in the heart. And so early erectile dysfunction should be alerting us to check for cardiovascular disease as well. And psychogenic. So again, as I said, the brain being the biggest sex organ in the body, this can really influence any situation and can influence erectile function significantly. I think in many situations, it's a combination of any or all of these, irrespective really of whatever the diagnosis is. Again, in our clinic, we see a lot of people with difficulties around erectile function, and oftentimes it's a number of any of these factors that are contributing. Changes in ejaculation, sometimes we can see delayed or premature ejaculation, again, because of potential nerve damage, or again, can be psychogenic or psychosocial factors that influence that. We can see little or no ejaculation, and again, if there's been a radical prostatectomy where the seminal vesicles and prostate have been removed, there won't be any ejaculate. That's a dry orgasm, so nothing is coming out there. And there can be little or no ejaculate also with radiation or androgen deprivation therapy as well. Urine leakage during ejaculation is called climacturia, and that can happen after surgery, after radiation therapy, and there can be pain with ejaculation as well. So with climacturia, just to make the point that can be a couple dribbles, that can be a lot, it can happen on occasion, it can happen all the time. It's very individual. Changes in orgasm, we know that after many of these treatments, first I should say that orgasmic dysfunction after prostate cancer has been very poorly studied. So the mechanisms involved remain to be elucidated. We don't know the details quite yet of what's going on, but we do know that this is very common after treatment for prostate cancer. So there could be changes in orgasmic sensation where there's decreased intensity. I would say for many men there's decreased intensity or absent orgasm. Very few men will actually report increased intensity of orgasm. There can be painful orgasm or dysorgasmia, and there can be loss of orgasm altogether, which is called anorgasmia. There was something I wanted to mention about that, just the prevalence. So the changes in orgasmic sensation after prostatectomy are about 30 to 70%. It's a very big range. Painful orgasm, about 20% prevalence after radical prostatectomy. Lack of orgasm altogether, again, between about 30 and 70% after prostatectomy. Body image. We know that there can be huge body image concerns after prostate cancer treatment with penile shortening, testicular shrinkage, gynecomastia, weight gain, weight loss. With penile shortening, we know that the potential loss of penile length and girth can happen after radical prostatectomy, androgen deprivation therapy, radiation therapy, and they're not really sure what the exact mechanisms are involved in the penile shortening, but they really are suspecting that there's a cavernosal hypoxia, so lack of oxygen to the tissues, which causes a profibrotic state and increased collagen deposition, and that's just kind of changing the smooth muscle endothelium in the penis. This, I think, is really, it's a big deal for many men, and it's a big deal in particular in the gay and bisexual community, where looks and in particular penile length and girth are really weighted heavily. And I think for many men, this, a lot of this body image stuff and all of this, the treatment induced changes, make us wonder, what does it mean to be a man? What is our masculinity? How is masculinity defined? Richard Wassersug, I know he's done a video before for you guys, And he's done a lot of work in this area about masculinity and the identity, and he's really got a lot of thought-provoking articles on how masculinity is defined and experienced in the context of prostate cancer. I know there's a video on your YouTube channel. And so, yeah, what do we mean? I found this little cartoon. You probably can't read it. How to be a proper bloke. It says, grow a mustache. Mustache screams, look at me, without actually screaming, look at me. Wrestle a bear. Nothing says macho like a dead bear on the dinner table, okay? Get some back hair. Reading on the toilet. Reading on the toilet confirms you are an intellectual. And eat meat with your hands. So, I mean, how do we define masculinity? What does it mean to be a man? How big of a deal is it if some of these changes are happening? What is that doing to your own manhood and your sense of identity? I think these are all important questions. Changes in fertility as well, and we know that many of the treatments that we give patients for any type of cancer can impact fertility. It can be temporary, it can be permanent. Ideally, these discussions on fertility preservation really should happen prior to the initiation of treatment. You can collect semen before treatment starts, and you can store it and freeze it for a future use. It costs about $400 for the first year's storage and about $200 every year thereafter, and that's something that is typically not covered by really any insurance plan. I did want to raise this because I did get an email question about this. I think it's really important, and we also had a patient in a workshop that we do a workshop for women with changes in their vaginal health after cancer treatment, and it's open to women of any cancer diagnosis. And she brought up that one of her friends had recently said that she was selfish for thinking about wanting to have a baby after she'd been diagnosed with breast cancer. And this is resonating with the question that was posed as well about a young man who'd had prostate cancer, and the family member had said, you shouldn't be thinking about a family or marriage or anything else like this now. Well, yes, you should, and yes, you can, and I think none of us know what tomorrow holds. Nobody would question somebody in the absence of a cancer diagnosis for wanting to start a family necessarily, so why should it be different? And I really felt for the woman in our workshop that she really wanted to have a baby, her treatment's been finished. There are no guarantees that her cancer won't come back, but there are no guarantees that any one of us are going to be perfectly fine tomorrow. So we were helping her get connected with the regional fertility clinic in Calgary and getting her some counseling and encouraging her to maybe either discuss with her friend how hard that comment was on her, or perhaps moving on from that friendship, because that was a very hurtful thing for her friend to say. So fertility preservation, again, as I said, it's best to talk about this before treatment starts. It's not, if treatment's already started, it doesn't mean there's no hope. It's just easier to kind of manage some of these things before treatment starts. That's not always feasible. That's not always practical depending on the type of cancer and the situation, the urgency of starting treatment. But if possible, see somebody first. And there are different organizations in Canada. Generations of Hope and Fertile Future both provide some funding to assist with the cost of fertility preservation for men and women dealing with cancer. Relationship changes. I think this is a very complicated topic for sure. You can see I put a lot of resources on this slide. I think this can be challenging for existing relationships. It can be challenging for new relationships that have just happened shortly after then the patient is diagnosed with cancer. That's a big challenge, but it's also challenging for people who've been married and together for many years. Starting new relationships, getting back out into the dating world can also be very challenging. When do you disclose a cancer history to a new partner? How do you talk about that? There's one person on one of the websites I've listed there who says she's a 35-year-old divorced mother, and she calls her cancer diagnosis her D-bag filter. So when she discloses that, that's her D-bag filter. If the person isn't going to be there and be supportive and accept it, that's good enough for her. She knows. I think it's challenging though. When do you disclose that? How will the person respond? In an existing relationship, how do you maintain your roles in the relationship? How do you preserve your individual independence in the relationship? What happens to the intimacy if one becomes the carer and one is the care recipient? There's some strategies for how to deal with that, and we'll talk about that in just a few minutes, but definitely the relationship situation can be very challenging. Partners as well, and this is an area that has received relatively little attention in the literature, unfortunately. but partners might feel fearful of causing pain or discomfort during sexual activity. They might feel unwanted or unattractive or even rejected due to the decreased sexual activity between the two. There might be a change in role, as I mentioned on the previous slide, from being a partner to now being a caregiver, and how that changes the dynamic in the relationship. There may be a sense of worry about potential impending loss of the partner, so some partners may start to pull away as a protective mechanism. And then partners may also have their own sexual health concerns, and I know for women, as we age, there's a real concern around changes associated with menopause and vulvovaginal changes, dryness and atrophy and stenosis and different things that can happen as well. So if there is any issue going on with a partner, that can complicate things as well. Specifically for the gay, bisexual, and men who have sex with men population, we know that these men experience the same sexual changes after prostate cancer that have been reported by heterosexual men. But there are a number of specific meanings and psychological consequences that this population attributes or attaches to sexual changes. Again, identity challenges, relationship challenges. I think there are some unique challenges in the gay and bisexual population. And unfortunately, not a lot of research has been done in this area yet. But we know that the prostate can be an intense site of sexual pleasure during receptive anal sex. And so if you're removing the prostate, you're removing that site of sexual pleasure. And that's not just for gay, bisexual, or men who have sex with men, but heterosexual partners can engage in anal play, and the prostate can be a site of pleasure that way as well. And so that's being removed. The loss of ejaculate carries particular significance in the gay and bisexual population, and the notion of semen exchange, visual semen exchange, is quite important in that population. So the loss of ejaculate is very important and a big loss. Rectal irritation or pain after surgery or radiation can lead to painful receptive anal sex. Inadequate penile rigidity, as I mentioned, the penis needs to be about 30% more rigid for insertive anal sex compared to penetrative vaginal sex. And there can be changes in sexual roles, so where some men prefer to be tops, then they may have to revert to being bottoms, and vice versa. The absence of erection, the visual absence of erection, so partners may say, they're not, the partner doesn't seem visually turned on anymore because the erection is gone, and that can be a big loss for them as well. Change in penile size, again, I think is important to any man, and in the gay and bisexual population, there can be a lot of comparison of penile size in saunas, bathhouses, and other places where men would be together. And so some unique challenges for sure. I think social support-wise, we know sometimes that gay and bisexual men who have not come out to their friends and family, they may then have less familial and social support. They already are a sexual minority, and we know that that's a negative predictor of quality of life following prostate cancer treatment. All of our educational materials tend to be very heterosexist. A number of good websites now exist, and I've included them at the end. But still, research on penile rehab strategies and all of the stuff that we're talking about in terms of how to manage these sexual changes, really all the research has been done with heterosexual couples and is focused on penis and vagina sex. So definitely there needs to be some more research to include other types of sexual activity and other lifestyles. Prostate cancer in transgender women, again, very, very limited information out there. Most transgender women will still have a prostate. So even if they've had gender reaffirming surgery, they will typically keep their prostate, because removing the prostate can cause bladder issues and incontinence issues and whatnot. So most transgender women will still have a prostate. They do receive feminizing hormone therapy, which could include estrogen as well as anti-androgen therapy and or alpha reductase inhibitor therapies. So the prostate definitely is androgen deprived. And so some people think that should reduce the risk for prostate cancer, but there are case reports in the literature where transgender women have had prostate cancer diagnoses. So, and again, because of the feminizing hormones and androgen deprivation, PSA is not a reliable indicator for prostate pathology in this group. We know that the risk is thought to be low, but it's not zero. And you can imagine it can be emotionally difficult to have a male-associated cancer as someone who does not identify as male. And again, I think most prostate cancer support groups and resources are targeted at men, but more are becoming inclusive, including Prostate Cancer Canada. There's information on their website about gay, bisexual, and men who have sex with men, as well as transgender women. Sexuality in advanced disease and end of life. We know that the importance that people place on sexuality does not change at end of life, but the expression might change. So sexuality was seen in one study that was actually done here in Calgary by Dr. Laurie Lemieux several years ago. She found that sexuality was not seen as being solely about sexual intercourse, but also included emotional intimacy, connection, verbal and non-intercourse forms of intimacy. And I think we see that in many situations of chronic disease and advanced illness. There are lots of barriers, as you can imagine, lack of privacy, shared rooms. There's lots of hospital and long-term care and hospice facilities that might not be seen as particularly inviting in terms of romance and things like that. Intrusion of staff, single beds. We don't have double beds in hospitals. I think even just to cuddle up with somebody in the hospital when you're feeling sick and scared would probably be of great comfort. And then there can be very intrusive equipment as well that can get in the way. Symptoms, again, can influence expressions of sexuality at end of life. Again, as I said, the focus might move more from sexual intercourse to other forms of physical intimacy. And there are many strategies that we can look to manage pain and other symptoms at end of life. And I think, involving home care and allowing partners to remain in that partner role. We say this really in any situation where there's a lot of caregiving tasks that have to be taken on by the partner at home. If you can, let home care come in. Remain the partner if you can, and step aside and let home care and the healthcare professionals come in to do some of the caregiving tasks. So interventions, what to do about all of this. I think really we need to take a very biopsychosocial approach to managing this, because as you just heard, sexuality is more than just the physical, more than just the biological changes that happen. We really do need to take a multidisciplinary approach. So that might look like some partner and person awareness, self-awareness, communication interpersonally, adaptability, psychology and counseling, I think, is always really important. Some non-invasive assistive devices, and then kind of on the table, but maybe not first line, would be a various number of different medical interventions. And things to think about when trying these different interventions. I think it's really important that the change or loss of sexual function, the change in sexuality, that's a loss. That's a real loss. And there's a grieving process, and I think we need to acknowledge that. This is an important part of quality of life, and when it changes or when it's gone, this is a loss. I think we need to be aware that sometimes the different options and strategies we choose to help manage sexual changes, they don't always work. So if we're trying medication first, it might not work. So just be aware that there may be some failure, but that doesn't mean that that's the be-all end-all and we should give up. Again, consider sexual activity even if low libido exists or there's no desire, no spontaneous desire. Consider flexibility in sexual practices if this is something that fits with your values. And work with erections of reduced quality. Again, you do not need a firm erection for orgasm, so you can still have good sexual satisfaction and pleasure even in the absence of a firm erection. And don't give up. This little duckling here, don't give up. Just keep persisting, and there's lots of different things we can try. Communication, I think, is really important. Patients might wait for their partner to initiate sexual activity, or partners might wait for the patient to initiate sexual activity or communication about it, and then nobody talks about it. And that's what happens in the healthcare system too. We as healthcare providers wait for patients to bring it up, and patients wait for us to bring it up, and nobody talks about it, and it just gets ignored. And so that communication component is very important. I think, be concerned about how your partner feels, take it slow, be patient. Dr. Lauren Walker and Dr. John Robinson and Richard Wassersug of UBC, Lauren and John are here from Calgary, and they've published a book, I know it's in your library as well, Androgen Deprivation Therapy, and they've got some strategies in there about how to deal with some of these changes. And then this was published a couple years ago as well about just some questions that might help stimulate some communication about sexual renegotiation. So what are you thinking? Is it okay if I bring you to orgasm through touching or oral sex, even if we're not having penetrative intercourse, or even if you don't have full erections anymore? How do you feel about me using sex toys? Different things like that. So these are some different questions that might help get the conversation going. Because this is challenging. If couples have not ever had these kinds of conversations before, it can be very difficult and challenging to bring this up. Improving intimacy. So again, I think we think often as penetrative sex as the be-all, end-all, and I'm here to tell you that it really shouldn't be, because there are many, many other things that you can do that can result in a very satisfying experience. We talk about emotional, sensual, and sexual intimacy, so different types. Being emotionally intimate with somebody is profoundly meaningful. You can be sensual, you can be physically intimate without having penetrative sexual intercourse. Different sensual activities. This makes me think often of the two that are in the bath. That's from the Cialis website, and there's a comedian, I can't think of his name right now, and he does this little bit called I Believe, and he said, I believe if Cialis really worked that well, those two would be in the same bathtub, not in separate bathtubs. But again, to make the point that sometimes it can just be nice to be in a bathtub with your partner or beside your partner, or doing different activities that you enjoy together, dancing, non-intercourse sexual activities. There's a brochure, I don't know if I brought it, actually, I can email it, called Other Course. There's a great website called Hot Octopus. They're out of the UK, and they've got a good section on outer course. So different things you can do that can be intensely erotic, intensely pleasurable, that do not involve intercourse. Very erotic, non-insertive intercourse, or Venus, again, the same kind of idea, where we're not talking about necessarily needing an erection. We're not talking about needing penetrative intercourse. And I'll tell you also, from the flip side, seeing many women in our clinic, penetrative intercourse is not something that is a reality for many couples for various reasons, because of medical conditions and various situations. So being creative and coming up with different ideas, I think, can be really helpful. Taking intercourse off the table. I don't mean if you were having intercourse on the table, take that off the table, but you can have it on the table if you want. But taking that off as kind of the be-all, end-all goal, and just saying there are a bunch of other different things that can be very pleasurable as well. John and Lauren also do some great work with sensate focus. And this is particularly helpful if pain has been part of the sexual experience for a couple. The first couple of weeks of sensate focus, you're just focused on touching each other, not sexually, not sensually, but just touching and talking to each other. And it gradually progresses to the point where you're touching genitals, you're touching different parts of each other, and talking to each other about what feels good and what doesn't. And there's a very kind of methodical, stepwise approach. And John and Lauren, as I said, are both very good at helping patients and partners to navigate that. Improving desire. Again, the brain, I think, is really key here. But being aware of responsive desire versus spontaneous. So you might not feel necessarily, that spontaneous desire or feeling in the mood might be lacking. But once you get into the situation where you're cuddling or where you're touching or where you're snuggling, that desire may come afterwards. Arousal may come first, desire may come later, desire may not come at all, and you can still have a satisfying sexual experience. Counseling can be very helpful here as well. Mindfulness-based meditation and different strategies there can be helpful. If on androgen deprivation therapy, now there's been some research to look at intermittent androgen deprivation therapy versus continuous. And particularly for people who don't have metastatic disease or they've got low-risk disease, taking breaks from the androgen deprivation therapy can also be something that might be helpful in terms of alleviating some of the sexual side effects. Improving erectile function. So I think, this cartoon's too small, but I think the big thing we want to know first is what's the reason for erectile difficulty, because sometimes that guides how we manage it. But there are many different strategies, I think, to look at, and some of them are medication related, some of them are non-invasive, some of them are various different assistive devices. And again, I want to make the point that I don't think the holy grail of sexual satisfaction is erections. I think men can still have very satisfying sexual experiences and even orgasm without erections. So I think they're not the be-all, end-all. This is just a diagram showing some of the different external aids for erectile function. So the top left is an external penile prosthesis. It's also called a belted prosthetic phallus in the medical term, or strap-on dildo. And some men, this is Richard Wassersug and his colleagues, have found that some men will even recover orgasmic capability despite severe erectile dysfunction when they use a device. So something about having the strap-on dildo on and the activity stimulating intercourse, the brain is remembering and those connections are remembering, and orgasm can still happen. Letter B there to the right of that one is a penile sleeve, and so again, depending on the size, shape, and thickness of the sleeves, these aids could be used for sexual intercourse by men with erectile dysfunction. Some are used with a harness and some are not. C, bottom left, is the elator. It's a penile support device. It can be used as a brace almost for the penile shaft. And then the vacuum erection device on the bottom right corner, and that's used to induce firmness and tumescence, I guess, in the penile shaft. One thing that Dr. Wassersug has made a point of is there's a hinge effect that can happen with vacuum erection devices. So typically you'll use a vacuum erection device. It will cause suction or negative pressure, I guess, to pull blood into the penis. You put a constriction band, pardon me, I've got one here somewhere. Anyways, constriction band at the base of the penis to trap blood in the penis. But what happens then is beyond that part where you've placed the constriction band, it's soft. The penis is soft, so the penis extends a bit into the abdomen or into the body, and so you get almost like a swivel or almost like a hinge. Typically, if you didn't have that issue, you would have firmness that would extend. And that firmness would originate deeper inside, more proximally. And so if you've got that constriction band on, there can be this hinge effect that can happen. And some devices are better than others at preventing that from happening, but definitely that can be a potential issue with the vacuum erection devices. The elator is a silicone piece of equipment that can help to support the penis for penetrative intercourse, and they are available for purchase via their website. They custom make them, so they have the men measure girth and length, and they're custom made. They're about $300 US per device. I haven't seen studies yet on the efficacy of this device, but it is an option. The medications, of course, probably have been one of the most widely studied, widely researched options for erectile dysfunction. These are phosphodiesterase type 5 inhibitors. We know them as sildenafil or Viagra, vardenafil or Levitra, or tadalafil, Cialis. And they all kind of work the same way. They cause smooth muscle relaxation and increased blood flow into the penis. They're not helpful in all cases of erectile dysfunction. It really depends on the cause. So if there's a lot of nerve damage, these drugs won't work. If there's a hormonal issue where testosterone's really, really low, sometimes these drugs won't work. If there's a major psychogenic issue where there's a lot of psychosocial distress, these drugs don't work as well. So it really depends. If it's a vascular reason or a blood flow issue, these drugs can work really well. They have a very similar side effect profile. The biggest difference really is the half-life, and so it's about 4 to 5 hours for Viagra and Levitra, and about 18 hours for Cialis, since that's why they call Cialis the weekender. So I remember a patient when I worked in Edmonton, and I'd given him a prescription for Viagra. He and his wife went home and had a great romantic dinner, and they both fell asleep. And he woke up in the morning, and the drug was essentially out of his system, and he wasn't able to have an erection. If he would have had tadalafil or Cialis, he probably still would have had the ability to have an erection there. But I mean, they're all similar in terms of how they work. As I said, side effects similar. They can cause headache, facial flushing, nasal stuffiness, transient or temporary altered vision, and they're usually pretty well tolerated with pretty mild side effects. You cannot take nitroglycerin or any nitrates while you're taking Cialis, or any of these drugs, sorry. It will cause a very low blood pressure. There's a new drug in the US called Avanafil, and it has a quicker onset, a shorter half-life, and you can give nitroglycerin or nitrates within 12 hours. But this is one thing they'll ask you if you go with chest pain to emerge. They'll ask you if you've had one of these drugs in the last 24 hours. Alprostadil cream. This is a question that was asked of me the last time I was here. So somebody in the audience had asked, there's a cream you can rub on that should help with erections. And so we know alprostadil, prostaglandin can increase blood flow and, or it can increase erections. And so its mechanism of action, it binds to the surface of smooth muscle cells, and it causes vascular smooth muscle relaxation that leads to erection. We use this in injections. We use this in the intraurethral suppository or Muse, but this is a cream. It goes by the trade name vibrators. Canada approved this for use in 2015, but the drug company that makes it has not yet brought it to the market. And I've been in touch with them because this question came to me by email a couple days ago. They're expecting to launch this in 2018 in Canada. In the meantime, it is possible to have this compounded at a compounding pharmacy. So it is applied to the tip and the head of the penis prior to sexual activity. It can cause some penile pain and redness because, again, of the increased blood flow. It's not considered first line, so if you were on the medications and they failed, this might be something else to try after having tried the medications. They have done several studies that have shown improvement in erectile function, including vaginal penetration, persistence of erection, and satisfaction when compared to placebo. It starts to work within about 5 to 30 minutes, lasts for about 1 to 2 hours. You can't use it more than once in 24 hours. So again, watch for this one. Should be coming in the next year or so. Other options, intracavernosal injection therapy. This is where we inject prostaglandin, or you can inject PDE5 inhibitors as well, medications that are going to cause improved blood flow, inject them directly into the cavernosal tissue in the penis. The needle is small. I know the thought of that, injecting something into your penis, is terrifying for most men. It's tiny, it's very, very little. You probably cannot see it from back there. And I have had the experience of teaching men to self-inject, and the first time is, I think, terrifying for most men, but once they've done it, they realize it doesn't hurt as badly as they thought, and it does produce pretty remarkable results. And so the injection can be particularly helpful if there's a neurogenic or nerve-induced cause of erectile dysfunction. And we usually give the first dose in the clinic, so we can see what the results are, and then we can tailor the dose to what you'd need. The second one there is the transurethral therapy. So again, alprostadil or prostaglandin going into the urethra. And this one is a pellet or a suppository going into the urethra. I can see why the appeal of the cream, where you rub it onto the tip and the head of the penis, would be preferable, because again, sticking something into the urethra does not sound particularly fun either. But it does work relatively well for men as well. And that one is available. The suppository, urethral suppository is available right now. Vacuum devices, again, I discussed on a previous slide, they work pretty well as well, with an efficacy of about 90 to 100%, but again, have some problems with the hinging, dexterity required. Again, it's not for everyone, but can work really well. Penile implants are kind of more of a permanent option, and they're are different types. So there's the inflatable implants, where there's a fluid-filled reservoir that's placed in the abdomen, and a pump with a release valve is placed in the scrotum, and there's inflatable cylinders in the penis, and so you can squeeze the pump and transfer fluid from the reservoir into the penis. Or there's semi-rigid or malleable rods that can be inserted, and those can be adjusted for intercourse. And that type of implant, the latter, the semi-rigid or malleable rod, the implant is always quite firm. And those have an efficacy of about 95 to 100%. So managing ejaculatory changes, I think it's important to acknowledge, again, particularly in the gay and bisexual community, the lack of ejaculate, just being aware of that, discussing with a partner. Some people like that's missing, some people don't. Depending on the particular relationship and partnership. Climacturia, where there's urine leakage during sex. So again, some simple strategies: emptying the bladder before sexual activity, avoiding caffeine, alcohol, diuretics, those kinds of things. You can use a constriction ring at the base of the penis, again, to help prevent the urine leakage. You can use condoms. There's been a couple of smaller studies, and one in particular that looked at pelvic floor physio and actually found that 50% of the patients who had pelvic floor physio improved in terms of the climacturia. So those are just some options to manage that. Orgasm, again, very limited studies done on orgasmic dysfunction after prostate cancer, so that really, not knowing the mechanism for the orgasmic dysfunction makes it hard to plan for proper strategies. But again, I think possible strategies would include psychotherapy or mindfulness-based strategies. Penile vibratory stimulation is being looked at as well. And there's different medications. So you can use pain medication if there's a lot of pain. Some people will use even local anesthetics if there's urethral pain and different things like that. Again, those are very individual-based and something to be discussed one-on-one with your individual physician or care provider. Tamsulosin or Flomax, there was one study that did find some improvement after the use of Flomax with orgasmic function, and cabergoline as well, which is a dopamine agonist that acts in the brain to normalize serum prolactin, and prolactin is really important for that refractory period. And so they found improved erectile function and libido in men with Parkinson's disease who were on this medication. So this may be an option as well, but not a lot of studies right now to look at ways to improve orgasmic function. Just a word about penile vibratory stimulation. So this is a study right now that's recruiting in the US. And in the past, penile vibratory stimulation was mostly used to stimulate an erection in men with erectile dysfunction and ejaculation issues in men with spinal cord injury. And so it works by stimulating branches of the pudendal nerves that lie alongside the penile shaft. And this stimulation causes a reflex parasympathetic erection through the activation of nerve terminal endings that release nitric oxide, cyclic GMP, cyclic AMP, and that causes cavernosal smooth muscle dilation and erection. And so there have been a couple little studies looking at penile vibratory stimulation in patients who'd undergone nerve-sparing radical prostatectomy. And they're seeing some promising results. Nothing conclusive as of yet. I think that we could definitely say that this should be done. This particular device is, it's a little interesting looking. I was showing my husband the slides for this presentation, and he called it the dong tongs or something. He says it looks like dong tongs or tongs. I'm like, oh, jeepers. Now the makers of this are probably going to sue me for saying that. But anyway, I think you know, if it proves to be efficacious, I think it's a non-invasive option. It might be an option for men to look at if the research supports its use. Testosterone replacement after prostate cancer. I'll say that this is still under investigation, but a lot has changed in the 2 years since I was here last in terms of what's happening with testosterone after prostate cancer. So it used to be no chance, no how. Now they're saying, I think, judiciously in certain circumstances, it may not be as dangerous as we once thought. And so there's this now saturation model for the relationship of prostate cancer growth and serum testosterone. So the traditional belief was that higher testosterone concentration caused increasing rates of prostate cancer growth, and that would be curves A and B in the chart. But so far, all of the available evidence is demonstrating that a powerful effect on testosterone on prostate cancer growth happens at low testosterone concentrations, but really little or no effect above the near castrate range. And so the relationship between testosterone and prostate cancer is shown in this diagram as curve C. So yeah, there's a threshold and there's probably a danger zone, but once you get above that or around that, it doesn't really make much difference. And so a couple of big articles have come out in recent years. This one just last year talking about testosterone therapy in men with prostate cancer, saying ultimately that some men may benefit. This conclusion says, an improved understanding of the negative effects of testosterone deficiency on health and health-related quality of life. So we know testosterone is related to health and quality of life. So when we're taking testosterone away or testosterone deficiency states, that's affecting quality of life and health. And the ability of testosterone therapy to mitigate these effects or help these effects has triggered a reevaluation of the role testosterone plays in prostate cancer. An important paradigm shift has occurred within the field in which testosterone therapy may now be regarded as a viable option for selected men with prostate cancer suffering from testosterone deficiency. So it needs to be somebody who's got symptom-related quality of life issues because of the low testosterone. B, it's only going to be safe to do this in certain populations. And so in some of these articles, they further define this as low-risk disease. So saying 1 to 2 years post-radical prostatectomy with a Gleason score of 6 or lower in the original pathology, no metastatic disease. It would be dangerous probably to put somebody on testosterone for whom is being treated with watchful waiting, so hasn't had surgery. Radiation, they're not sure what the status would be after radiation, if it would be safe to put men on testosterone. So the big takeaway here is that this is still under investigation, but I think that it's changing a bit. Just like we know in the female world, we're not as scared as we used to be about hormone replacement therapy in certain circumstances. So again, judicious use, low dose probably in very certain specific clinical circumstances. A quick word about herbal or natural products. Be cautious about the use of herbal or natural products. Sometimes they come across as being safe, but they contain ingredients that may interact with your other medications. They may cause adverse side effects of their own. A few years ago when I was at the World Meeting on Sexual Medicine in Chicago, there was a presenter who talked about herbal and natural performance enhancement dietary supplements purporting to have PDE5-like or Cialis Viagra-like activities, the so-called gas station Viagra that you can buy at gas stations and whatever. 81% of the samples contained an active ingredient, which was good. 20% of them, though, were overpotent, so probably stronger than they needed to be. 38% of them actually contained tadalafil or sildenafil, so Cialis or Viagra. 8 of the samples contained both of those drugs, which you wouldn't need both. They had labeling inadequacies, no expiration dates, lot numbers weren't included. Other analyses found that some contained fillers like brick dust or ink toner from printer cartridges and such. So just be cautious with the drugstore Viagras and things like that. Sexual enhancers, the fun part, I think, of this talk for the next couple minutes, and then I'll be done. So lubricants, I think for men and women in heterosexual, same-sex relationships, whatever, I think lubricants can be very helpful, particularly when we're talking about reduced erectile rigidity. I think lubricants can be very helpful. They reduce the friction. They can help things slip into things more easily. I did think about, I've got a big box of lubricants here. I thought about throwing them out by the handful to you guys, but that's probably not politically correct, and I've got samples up here if you'd like to take them afterwards. They come in different types, silicone, water-based. Those are the two that we'd recommend, are the silicone and water-based, and they come in different configurations, I should say, I guess, different types. So there's organic, paraben, glycerin, free, all kinds of different products that sometimes have additives, flavors, and different stimulants and things like that, which can sometimes be a bit irritating to the penile and vaginal tissues. And so we just typically recommend that people use products that don't contain a lot of the different additives. So something like Good Clean Love, that's the samples I have here. They're paraben, glycerin-free, fragrance-free. You can also use things like coconut oil, just the regular coconut oil that you buy at the grocery store or Costco or wherever. That can also work very effectively as a lubricant, and other oils can as well, olive oil and such. Can be messy on the sheets, so some of the water-based options will wash away a little bit more easily, but don't retain the slipperiness component as well as the silicone-based oils do, or lubricants do. Vibrators. So it would be a little bit of an extrapolation, because there haven't really been any studies done to look at the use of commercially available vibrators on erectile function or orgasmic function. But theoretically, if the other types of vibrators that they're using in the studies work, there may be some benefit to using the commercially available vibrators. And certainly, we do encourage women, when they come to our vaginal health workshops, we do encourage them to use vibrators, because we speak about dilation for women after menopause or after cancer treatment that causes profound vaginal dryness and stenosis or changes in the vagina. So you can dilate a vagina with a dilator, which is doesn't vibrate, and its sole intention really is to dilate the vaginal tissues. You can dilate a vagina with vibrators as well. And so similarly as well, there's some evidence to suggest that gentle vibration on the frenulum of the penis can be very erotic, can feel very nice, can help stimulate erection, can help potentially stimulate orgasm as well. So there's a bunch of different configurations and types of these. There's ones like the Oh My Bod that will vibrate to the beat of the song on your iPod. There's ones that look like little lipsticks that plug into your, I won't plug this into Dave's computer, but they plug into you to recharge into your computer. The one that I'm really quite excited about that just came today actually was you could use it as a constriction ring at the base of the penis to trap blood in to help with erectile function, but it vibrates as well and can be used solo, could be used with a partner as well, and it can stretch to accommodate an erect penis, or it could also be used in a more flaccid state, but could be worn at the same time as intercourse with a partner, or again, on one's own. And this one is the one that I'm hoping to get my hands on. It's a product that is made in the UK, but it's almost like a wraparound sleeve. So again, would accommodate a flaccid penis, or penis of any size. And again, it's got oscillating movement that's a bit different than some of the traditional vibrators. And this product can be used solo or together with a partner, again, to help stimulate erectile tissues and erection and potentially orgasm. So, okay, body image, vajazzling came out a few years ago, and so you can decorate down below if you're so inclined. Not to be left out, they've now introduced pajazzling for men, or decorating. So there's different things you can do if you're so inclined to kind of spice things up, and if it suits you, have fun with it in any way, shape, or form. It's just about kind of being open to different ideas. So I've just got a couple of slides here to finish up, but this is one that came from Lauren and John again, and I really like this one. It's probably a bit hard to read from the back, but it's just kind of showing that pretty much everything I've discussed this evening so far, it's all pieces of a very intricate and complicated puzzle that I think there are lots of options if you keep an open mind. I won't use these vibrators. I was just about to use it as a pointer, but I'll maybe just walk over instead. Just to say, you know, in terms of relational intimacy, there's emotional connection, shared interests, shared values, shared dreams. This is a place, I think, where counseling and psychotherapy is really important. There's a lot of different erection-independent activities that can happen. So sensual massage, genital caressing, mutual masturbation, oral sex, outer course, deep kissing, the use of different sexual enhancers or sex toys. There's erection-dependent sex, which you'll notice is actually quite a small piece of that puzzle. But there we talk about things like the PDE5 inhibitors, intracavernous injection therapy, VEDs or implants, a prostatal cream. Big part of the picture there, again, the physical and emotional affection and intimacy, holding hands, kissing, touching, cuddling, all of that stuff. And I think there's places we can intervene here medically if we need to. So I really would encourage you to continue talking to your providers. I'll mention it here on this slide. We now have a sexual health clinic at the Cancer Center. It's a pilot project. It's started back in January, and it's got funding for 18 months. We see people who have not been seen necessarily at Tom Baker before. So if you've been seen at the Prostate Cancer Center, we can still see you through our clinic at the Tom Baker. It's multidisciplinary. So I think pretty much every patient and partner we see, we try to see them together. So myself and John or Lauren, so we're taking a very combined approach. We're dealing with the physical stuff, definitely, but also the psychosocial stuff. We encourage partners to come. If the patient has a partner, we like to see both. There's also PCCN, of course, Prostate Calgary. The Prostate Cancer Center Calgary's got some workshops on androgen deprivation therapy, intimacy, and you can register by calling the Prostate Cancer Center directly. There are lots of books, websites, brochures, websites. I've compiled a list here, and I can make sure you all get this list. It's best to not just type sex into a Google search, or it can be interesting if you do that. You can get a lot of different websites pop up that you might not want to actually look at. Again, a bunch of different books that are here. I've read most of these. I've got a few extra copies of the book What Men Won't Talk About and Women Need to Know by Glenda Standeven, who was here a couple years ago as well, speaking to this group. a whole bunch of websites, as I mentioned. So I find the prostate cancer organization in Australia and the UK to be very comprehensive and provide very good information, as well as PCCN Canada and the Calgary branch as well. Again, these are resources specifically here now for gay, bisexual, men who have sex with men, and to a lesser degree transgender, because there's not a lot of resources out there right now. And again, lots of brochures. Here's some websites. I'll give a shout out to Come As You Are that sent me this. I thought this was a really neat idea. Again, because it can be used as an erection ring placed at the base of the penis to trap blood, but also has a vibrating function. And I ordered this, I think, last Thursday, and it came today. So I think they're a great option. They've got a lot of very sex-positive information on their website, as do many of these other sites as well. That can be a bit intimidating to go into a sex store or to order something online. So we're trying to compile some resources and products that we can have to show people. And I would encourage you to come up afterwards and feel these and take a look at some of these products. And again, as I said last time, they've never been used. They're just for demo purposes only. They're brand new. But they are, I think it's quite interesting to actually see what they feel like and see what they look like up close. There was something else I was going to say about that. At any rate, same in the clinic. If you come to our clinic, we have these things available to look at as well. So I think just the final couple messages here, it's common for changes in sexuality to occur after a diagnosis of any type of cancer for both the patient and the partner. There's a lot of different things we can do to help, non-medical and medical interventions alike, that can really help to improve sexual function. Try to let go of the assumptions and expectations about sexual function. Really, there's no right amount of desire, there's no perfect relationship, and there's no such thing as a normal sex life. It's all very individual. And if, as a couple or as an individual, these changes don't bother you, that's perfectly fine too. Only when it becomes an issue and it's causing distress to you, the patient, your partner, and you want things to change, that's when we want to help. But if these changes are happening and it's not a bother, then there's no need to intervene. Talk to your healthcare provider to find out what options are best for you. I know now at the Cancer Center, they are referring people left, right, and center to our clinic. I think it's great that we've got the clinic. We hope that it will continue running. I think if you have an option like that, the other healthcare providers are more inclined to ask the questions because they may not have the time or the knowledge or the experience to address these issues, and so often the question just doesn't get asked. If something's not working, don't give up. Try something else. There are a lot of different options. And keep talking to your partner, to your healthcare provider, and yeah, don't give up. And I'll end with a little humor as well. It says, "Oh no, I said I've got acute angina." And I'm happy to take questions here now. I had asked in advance of today if people would email questions in, and as I said, I did get a couple. So one was about the young patient with prostate cancer and the family encouraging him to just focus on treatment and kind of set aside looking for a relationship, looking for potentially marriage and or kids. I think you have to live your life every day and do what makes you happy, and there's supports for people in place, and we would encourage people to continue to pursue their dreams. And I can understand concerns around the family worrying about things like that, about potentially starting a family and perhaps the person not being around to continue to live long enough to see the family grow up, but there are no guarantees for any of us. So that's a tricky situation. We've got counselors at the Cancer Center. We've got fertility preservation specialists in Calgary that are ready to see our patients with cancer kind of on a next day or a very urgent basis. So there's lots of options there in that regard. The other question was about the alprostadil cream, Vibrators. I'm linked up now with the company that's marketing it in Canada, so as soon as it's available, I'm sure you will all hear about it, but in the interim we can compound alprostadil gel to probably produce similar results. It may not be identical, but hopefully it will be similar. Any questions from any of you?
What are the hours of your clinic?
Yeah, so that's unfortunate in some ways. So we got funding from a private donor. Our clinic runs once a month. It's a half-day clinic on a Friday, and it runs from 12:45 to about 5 p.m.
This is the Oasis Clinic?
The Oasis Clinic, yeah, at Tom Baker. We're booking now into November because, again, it's just a once-a-month clinic. But I'm confident, maybe a bit naively so, I'm confident that we'll make the case that this is very much a need. Again, we're getting so many referrals. We have people fill out questionnaires before they come to the clinic, and then at different time points afterward, just to see if there's been any positive impact. We hear from so many people that this just goes unaddressed, be it that healthcare providers don't have the training or the time or the desire to address this issue. It just doesn't get talked about. And some of these changes get very, very bad before people come to see us.
So is it a by referral to access?
Self-referral, yeah, you can take my
Self-referral.
self-referral if you like, or your clinician. So your oncologist or urologist or whomever can refer, but self-referral as well. And I've got some of my cards here. It's got the phone number for the clinic. You can call and say you'd like to be seen in the clinic, and it's that easy. Yeah.
Reanne, let me thank you for a very comprehensive treatment of sexuality and cancer, prostate cancer in particular. I was going to ask you that very question about self-referrals, and you've answered that. You mentioned about the phone questionnaire. Did you want to still proceed with that, or do you think it's something you want to not?
My poll?
Yes.
That's okay. I'll leave it this time, and
Okay.
maybe next time I come back, if I come back again,
Yeah.
if you invite me back.
Okay.
It's just kind of interesting to see. Some of the questions I
Yeah.
had were, is this an issue for you? Have you had issues with sexual health after your diagnosis? Have they been addressed by your healthcare providers? Do you want help for these? Are they causing distress? So I had a question for partners and a question for the person diagnosed with prostate cancer. Is this bothering you? Is it not bothering you? And the final question I had was, what do you see as the most important aspect or element required for sexual satisfaction? And it was a choose one of these. Of course, the option was none of the above or all of the above, but I was just curious to know what everyone thought. And again, partner and patient perspective, because I think sometimes we have different views about what we think the other finds to be important. So another time.
I think the different views, I mean, well, I look around at the membership here, and we're all in that greying community. I mean, our executive director and our board member, Jennifer, of course, with the exception. But what I think you have to do is look at your presentation and put it in context of your age group, you know. I mean, someone in their 40s that's dealing with prostate cancer would answer many of those questions or have issues with those points, you know, versus someone in their 70s or beyond. You know?
Yeah, and you know that as that brings up the important point that as we age, these things change anyway.
That's right.
And the importance we place on these things may change as we age as well, and that's okay. So I think, yeah, we definitely would get different responses depending on where people are at and what stage of their life and their relationships and things like that. But again, to make the point that there's no one size fits all answer for any of this. It's very individual, very unique, and very personal. So yeah, again, just to encourage everyone to ask questions if you can. If you're shy tonight, take my card and email me. And if you feel like you would like to be seen in the clinic, definitely I would encourage you to give our clinic a call.
Thank you very much.
Thank you.
Great.
Thanks for your time.